Good morning. Welcome to our CU session. Today, we will be critically appraising an implementation trial. We had an orientation on implementation research by one of our guest faculty, Dr. Marlena from the University of Melbourne. So we thought, in continuation of that, we will critically appraise an article on implementation science. And I hand over to Dr. Joseph for the critical appraisal. Thank you, Dr. Joseph. Over to him.
Thank you, sir, for the introduction. For today's CU presentation, we'll be doing a critical appraisal of an implementation trial using the assess tool. So first, giving a small synopsis of my overview of my presentation. First, we'll be seeing what is the definition of implementation science. We'll be seeing how it is different from effectiveness and efficacy studies. We'll be seeing some 2 to 3 practical examples of studies using implementation science. Then we'll be looking at what are all the common models that we use to analyze and implement implementation frameworks. And there are multiple ways to assess outcomes of implementation science, which we'll be having a brief overview. Then in the end, we'll be looking at what are all the tools that we have to assess implementation research. And we'll be doing a critical appraisal of an implementation study on AI-based stethoscope in the end. So what is implementation science? Implementation science is a scientific study of methods used to promote the systematic uptake of research findings and other evidence-based practice into routine practice. And hence, thereby, it improves the quality and effectiveness of health services. So how is it different from efficacy and effectiveness study? Say, for example, we are evaluating a new drug for heart failure. The first trial that we'll be doing is an efficacy trial wherein we'll have a fixed ideal setting, a fixed inclusion criteria, fixed exclusion criteria. The entire the scenario will be a controlled setup. And here we'll be assessing whether the drug is effective in a controlled setting. Whereas in effectiveness study, the focus is on whether the drug works in a real world setup. And whereas in implementation study, here our focus will be on how to make the intervention which is effective to come into practice. So it involves multiple different layers of framework, which includes stakeholder engagement, resources, and availability of training, the community setting, and the healthcare system. And we'll be seeing it in the coming slides on how to bring an evidence into practice. So first scenario here is a 60-year-old gentleman who's been diagnosed with heart failure with reduced ejection fraction 1 year back. He has come for regular follow-up to the OPD. His blood pressure is 120/70, his heart rate is 72 per minute, and he has normal renal function. And these are the list of his current medications. Can you identify where we are missing out? What is wrong in this prescription? So one thing you have been correct in pointing out is that there is no SGLT2 inhibitor. Anything else that is missing out in the prescription? Anything else that can be better in the prescription? Yes, this patient has been under follow-up for the past 1 year, but despite that, he has not been on target doses of the heart failure medications. So this is where implementation science comes into practice to find out what is the reason why we have not been able to put evidence into practice. So this is the timeline showing the numerous heart failure trials that have shown efficacy of GDMT in preventing mortality and heart failure admissions between 1985 to 2020. Say, for example, we have the RAILS trial showing the efficacy of spironolactone in heart failure. We have the Paradigm HF trial showing the evidence of ACRBs in heart failure. And we have the DAPA HF trial showing the efficacy of dapagliflozin in heart failure. Though we have numerous studies to say these heart failure drugs are effective, the practicality and how much we have been using it in clinical practice has still been dismal. So this was one review article in the European Society of Cardiology published, which assessed the state of implementation of GDMT in routine practice and how much of the target population are on the target dose of heart failure drugs. So here we could see that multiple trials in Europe, Sweden, and even in Asia have shown that only about 60 to 80% of the participants have been on a beta blocker or on a ACE inhibitor, and the implementation of mineralocorticoid receptor antagonists and SGLT2 inhibitors have been lower, like between 30 to 50%. And when it comes to reaching target dose, the numbers are even lower, where we could see that uh, the target only about 40% of the participants in the Sweden trial had been on target dose of beta blocker, and only about 50% of the participants have been on the target dose of an ACE inhibitor. In Asian trials, the numbers are even lower. A similar study from our own Vellore heart failure registry has also shown similar findings, wherein The implementation of guideline-based therapy was only about 41.9%, despite being so much evidence to say it is effective in heart failure. So what are all the factors which are behind why we are not able to implement this GDMT into routine practice? There can be numerous factors. One can be because in terms of safety, say for example, a patient has severe hyperkalemia, restricting the use of an ACE inhibitor, or the patient has a low blood pressure, not allowing us to increase the GDMT. Second thing can be poor tolerability of the drugs by the patient. Third thing could be poor adherence of the patient. Fourth thing can be from the physician's perspective, something called as physician's inertia in initiating guideline-directed medical therapy, and missing the patient on follow-up, not keeping the patient under close follow-up, or all other factors which are implicated in not reaching target drugs in heart failure management. So this implementation science aims to bridge the gap between what we know and what we do, which is called as the know-do gap. So studies have shown that for a research finding to come into clinical practice, it takes an approximate duration of about 17 years. And even at the end of 17 years, only 14% of research findings are actually put into practice. So this no-do gap is aimed to be bridged by using the phenomenon of implementation science. So this is another scenario. Here is a 68-year-old man who was presented with 1 hour history of right-sided weakness and slurring of speech. His CT brain has shown no hemorrhage and he's eligible for IV thrombolysis. However, the patient has not received a thrombolytic agent even at the end of 4.5 hours in the hospital. What do you think could be the reasons as to why the patient did not receive a thrombolytic agent? Any factors that you think would have delayed the administration of thrombolytic? So one reason you have quoted is right, the time taken for procuring the thrombolytic drug from pharmacy. So a research trial works in an ideal scenario and where everything is controlled, everything there's a fixed protocol on how things to be done. Whereas in real world practice, it is not essentially so. There are numerous practical difficulties that we face when we implement a efficacy trial in routine practice. So here, major issues can be in terms of the time taken for registering of patient in the hospital, time taken for procuring the drug from the pharmacy, the time taken for prioritization of the patient in the imaging, in the CT or in the MRI imaging. There may be numerous other patients who have been waiting, because of which this patient's imaging could have been delayed. So this is again an evidence, number of studies which showed thrombolytic agents are effective in stroke presenting within the window period of 4.5 hours. So despite us having these many trials showing evidence, how much we have been able to utilize it in practical setup is still dismal. So this is one trial called the HASTE trial published in AHA, which has identified what are all the factors which are responsible as to why we are not able to implement this thrombolytic agent within the window period. And in this study, they have found out that certain things like EMS pre-notification, using the possibility of an unknown registration, and shifting the patient directly to the CT scanner, and administration of the thrombolytic at the CT scan setup itself has been shown to decrease the door to needle time in patients with acute ischemic stroke presenting within the window period. So these are all some evidence of how implementation science can be implemented in routine practice. So are there any fixed frameworks for how should we practice implementation science? There are numerous frameworks to guide how we should experiment implementation science. One such framework is the CFIR framework, which is used to find out the determinants of implementation. What determines whether we are able to implement study finding into routine practice. The determinants can be at the level of the intervention, it can be at the level of the outer setting, it can be at the level of the inner setting, or it can be at the level of the process, or it can be at the level of the individual. Say, for example, the previous scenario where we used the utilization of a thrombolytic agent for stroke. Here, the intervention, first factor to consider as the determinant is the intervention. We should have sufficient evidence that the thrombolytic agent is effective. It improves outcomes, it decreases mortality, or it decreases the MRS score of the patient. And it should not be complex, it should be cost effective. An outer setting is that the government should have a fixed policy, it should have enough resources to implement the drug in clinical practice. Inner setting is nothing but the hospital setup and the facilities available in the hospital. We should have sufficient facilities to administer the thrombolytic agent. We should have sufficient facility to manage the complications. Say, for example, a patient develops a hemorrhage after the thrombolytic agent, the hospital should be sufficiently equipped to manage that complication of thrombolytic agent. And if it is a thrombectomy, we should have the facility of an interventional radiologist who knows how to do the procedure. And the individuals involved should have enough knowledge about the drug and how to administer the drug. And the process also should be in accordance with the how the efficacy trial had shown. So now the next framework that I wanted to introduce is the re-aim framework. This is the previous framework that we saw was to identify the determinants of implementation science, whereas the re-aim framework is to evaluate how implementation science is effective in clinical practice. To evaluate whether implementation science is effective, we evaluate it under the following domains. How much has the study, how much has it reached the population? Is the intervention effective in the population? Is the intervention adoptable, whether the new intervention can be adopted to the health system of the country or the hospital, and how do we ensure that the intervention is delivered properly, whether is it delivered as per the initial protocol shown in the efficacy study, and whether it is sustainable in the long term. These are all the framework through which an implementation study should be assessed for outcome. And how is implementation research different from clinical research? For this, I've quoted on Dr. Merlina's seminar on implementation science, which was given in CU in December 2025. So in clinical research, the objective is to evaluate a drug or an intervention, whereas in implementation research, the aim is to evaluate an implementation strategy. The population here is a specified patient group in clinical research, whereas the population intended is the healthcare professionals in implementation research. The intervention is a drug, whereas here in implementation research, it is an implementation strategy. Say, for example, a checklist for DVT prophylaxis. Comparator arm is usually placebo, whereas in implementation research, the usual strategy that is routinely followed is used as comparator. Outcomes in a clinical research can be efficacy or in terms of safety outcomes, whereas in implementation research, the outcome is in terms of how much is the practice, how much have we achieved practice change. So how do we bridge the no-do gap? There are three key strategies as to how we can bridge the no-do gap. One is to use the implementation science framework to identify what are all the determinants which identify what are the barriers or what are the enablers that are implicated in bringing a research finding into clinical practice. Second is to involve the stakeholders, say for example the patients, the government, or the whoever are involved in the delivering of the target intervention to the population. They should be involved and they should receive adequate training and support regarding the intervention so that we can bring it into real world practice and application. So there are numerous frameworks for implementation. Two of which we saw, which included the CFIR framework and the REAIM framework. Other frameworks include the KTA framework, the TDF framework, and the PRISM framework, which I'll not be discussing in detail. So there's also another approach to implementation science called the French approach, and it is a 4-step approach towards practice change. How do we develop a implementation intervention? It requires 4 steps. The first step is to identify who needs the intervention and what intervention, how differently. The second step is to identify, using a theoretical framework, what are all the barriers and enablers that have to be addressed. Step 3 would be to find out which intervention components could overcome the modifiable barriers and enhance the enablers. And step 4 is to find out how the implementation outcomes can be measured and understood. So one practical scenario that I would like to put forward before assessing this framework is that though we know that in patients who are immobilized require DVT prophylaxis, multiple studies have shown that only about 30 to 40% of eligible patients receive DVT prophylaxis in India. So why we are not able to implement it to all our patients who are eligible for DVT prophylaxis? So if we apply this framework, the step 1 would be to identify who needs to do what differently. So for this, we'll be using the AACTT domain and define step 1. Here the action would be DVT prophylaxis. The actor would be the doctor per se who should be initiating the DVT prophylaxis. The context will be in patients who are admitted in the inpatient facility and who are immobilized. And the time period would be the duration of hospitalization or the duration of immobilization. The step 2 would be to assess the factors that will be influencing behavior change. So this is the COMBI model of behavior change, and it says that for a behavior change, the factors that influence behavior change are capability, motivation, and opportunity. Say, for example, in our scenario where for DVT prophylaxis, capability would mean knowledge of the doctor about DVT prophylaxis and how much it is helpful to prevent DVT, and knowledge of the doctor to assess the bleeding risk as well in the participant before initiating DVT prophylaxis. The doctor should be motivated to initiate DVT prophylaxis among eligible participants, and there should be enough opportunities for him to do so in the hospital. Say, for example, a patient has a high bleeding risk for contraindicating DVT prophylaxis. There should be some maybe a pneumatic compression device available in the hospital, which can be utilized for behavior change. So third thing is to find out how can we change behavior now. Now that we have identified what are all the factors that influence behavior, how do we change the behavior? For this, we can use something called as the behavior change wheel, which helps to identify how we can implement behavior change. Here we saw that factors influencing behavior include capability, motivation, and opportunity. Some factors through which we can implement behavior change is at the individual level is like using education, using persuasion, using coercion, using adequate training of the participant. Say, for example, if many of the doctors do not follow hand wash techniques at the bedside, one thing can be to train the doctors and train the nurses on what are all the steps of hand washing and how effectively it prevents secondary infections in the hospital. And using modeling techniques, using environmental restructuring and restrictions, we can effectively make sure that an effective intervention is brought into clinical practice. And at the policy level, things that can be done are fiscal measures, implementation of guidelines, environmental and social planning, communication strategies to inform the behavior change to the masses, enacting appropriate legislations and appropriate regulations. Step 4 will be to measure the implementation outcomes. Say, for example, for an efficacy study for a new drug, we measure outcomes in terms of how good the drug is in preventing a heart failure, how good the drug is in terms of mortality, how good it is in terms of symptoms relief for the patient. Like similarly, for an implementation outcome, we measure the outcomes in terms of coverage, acceptability, adoption, appropriateness, feasibility, fidelity, costs, and sustainability. Coverage implies the degree to which an eligible population receives the intervention, and acceptability is nothing but how well are the participants which is the doctors who know about the study finding are able to use it in the routine practice. And adoption is nothing but identifying the factors which influence the institutional or the government's decision to implement the practice into clinical practice. And appropriateness is to find out whether the new intervention can be integrated into the pre-existing healthcare setup. Feasibility aims to find out whether the extent to which the intervention can be carried out in a particular setting and to a person who can deliver or use it. And fidelity is nothing but measuring how well the intervention was implemented as it was designed in the original efficacy protocol. And a good implementation study should also measure the costs involved in implementing the study and the sustainability of the intervention on the long term. So before going into the critical appraisal for our study, I'd like to put forward a scenario. Here, this is a 55-year-old gentleman who has come to a primary care clinic with bilateral leg swelling for 2 months. He's a known diabetic, and on examination, you note that his JVP is normal. The general practitioner here, he was thinking about the possibility of a heart failure, but his auscultation findings were subtle and he was uncertain about the diagnosis. So the question that we'd like to put forward in this scenario would be, will an AI-based stethoscope help in the diagnosis of heart failure in this patient? And the implementation question for focus today would be, will primary care physicians be inclined to use this AI-based stethoscope in routine practice? So to find the answers to this above question, I'll be critically appraising the tricorder trial, which was published in Lancet in the year January 2026. It is a cluster randomized controlled implementation trial analyzing triple cardiovascular disease detection using an artificial intelligence-based stethoscope in the United Kingdom. So a brief introduction about how the AI-based stethoscope works. This is the AI-based stethoscope which was used in clinical practice, and it is connected to the participant's smartphone using Bluetooth, and the phone in turn is connected to a cloud-based AI algorithm. The user of the stethoscope is supposed to keep the diaphragm of the stethoscope in the pulmonary position, and the stethoscope should be kept in place for about 15 seconds And the 15 seconds should have proper ECG recordings and phonocardiogram recordings documented. And this information from the stethoscope is transmitted to the smartphone of the doctor using Bluetooth, and from the smartphone, the data, the electrocardiographic and phonocardiographic data are uploaded to a cloud-based AI algorithm. The AI algorithm analyzes the report and gives a result as a binary outcome as to whether or not the patient has heart failure, whether or not the patient has a atrial fibrillation, and whether or not the patient has a valvular heart disease. Yes.
That means they must have an ECG electrode as well at the same time.
This stethoscope itself has the ECG recording in it integrated. Yes, sir. It measures the phonocardiographic recording as well as the ECG recording per se.
Electrodes. So that device
It is a
itself has the ECG.
it is a part of the same device. So before I go into the critical appraisal, I just wanted to give a brief overview about the reporting guidelines and the critical appraisal tools that are available specifically for implementation research. So this is the commonly used reporting guidelines, which include the STAR-I checklist, which is a 27-item checklist to report implementation studies. And there are numerous tools to critically appraise implementation studies. One includes the New York University's tool for assessing implementation science, which also includes a part of the CASP questionnaire. And other tools to assess implementation science are the Assess tool. And we also have a special tool for low and middle income countries called the Catalytic tool. For my presentation, I'll be using the Assess tool and the New York University's tool for critically appraising my article. So the first question in my article would be, are the results of the study valid? Did the study address a clearly focused Picot statement? For this, I have given a yes. The rationale behind the study is that atrial fibrillation, heart failure, and valvular heart disease are all common, detectable, and treatable conditions which are usually diagnosed only after a patient presents to the emergency department in failure. And many times they have found that at least half of these patients have been symptomatic and have presented to primary care before they have presented to the emergency department, where a possible diagnosis could have been missed. So this trial aimed to find out whether this AI-based stethoscope can improve the detection rates of heart failure in primary care practice. So the Picot statement of the study, the population included were adults aged more than 18 years or older attending NHS primary care. And the intervention here was an AI-based stethoscope, which was used at the discretion of the clinician. The control was routine practice to diagnose heart failure or other heart ailments. And the primary outcome that the study authors wanted to find was the incidence rate ratio of newly coded diagnosis of heart failure. The co-primary outcome was to find out the rate of detection of heart failure in the community versus hospital admission after integration of the AI-based stethoscope. The time period was 1 year, and it was a primary care setting. The study design was a pragmatic, cluster randomized, controlled implementation trial, which followed a hybrid design. I'll be coming to what is hybrid design in the coming slides. So this is the usual pathway by which currently heart failure is being diagnosed in primary care in the UK, which is a part of the NICE guidelines. The patient with a suspected heart failure in primary care tells the patient reports the symptoms, and patient undergoes a clinical examination by the doctor. And based on this, the doctor decides to order NT-proBNP, and based on the NT-proBNP, subsequently an echo is done and a specialist review is done. And based on this composite outcome, the patient is labeled as having or not having a heart failure. This study wanted to implement AI-based stethoscope on top of the usual practice. The secondary outcomes that the study wanted to find was the detection rates of atrial fibrillation and valvular heart disease, and the use rates of AI-enabled stethoscope, and what are all the barriers and enablers of utilizing the AI-based stethoscope in routine practice, and to find out the diagnostic accuracies of an AI-based stethoscope in clinical practice. And this is a type 1 hybrid model, whereas though there's a clear-cut definition of an efficacy study and implementation study, in real-world practice, a study might not essentially be only an efficacy study or an implementation study. It can be a combination of both. Hybrid type 1 study is one where the main outcome of the study is to test the clinical information, where on the other hand, it also simultaneously gathers information on implementation science. And hybrid type 2 model is giving an equal weightage to both efficacy and implementation science. And hybrid type 3 model is to is a model wherein the primary aim of the study is to assess the implementation science, meanwhile simultaneously gathering information about efficacy. Our study was a type 1 hybrid study design. So second question is, was the intervention, practice or service clearly measured based on an IS framework or model? In the preceding slides, we had seen some framework or models like the CFIR framework and the REAIM framework, but the study per se did not use a clear-cut IS framework based on which they have done the study. So hence I have given a no to this question. So was the population addressed in an acceptable way? For this, I have given a yes. These are the baseline characters of the study. The intervention group had about 7 lakh participants and the control group had about 8,51,000 participants. The mean age was about 44 years. And there were about 30% of the participants being of Asian origin. And the comorbidities per se was also more or less equally distributed among both the intervention and the control arm. And the inclusion criteria was that anybody who was more than 18 years coming to primary care practice was eligible to be part of the study. And the healthcare system per se should have the ability to test for natriuretic peptide and send the patient for an echo subsequently if they have a suspicion for a heart failure. Those healthcare setups with poor Wi-Fi or mobile data connectivity and those who did not provide face-to-face consultation were excluded from the study. So here the unit of study was not participants per se, whereas the unit of the study was the clinical practice, or the hospital per se was the individual unit of the study. So coming to the sample size calculation, the study authors had assumed that the baseline incidence of heart failure was 0.62 per 1,000 patients per year. And the study authors had assumed that using this AI-based stethoscope, they'll be able to identify about 22% more cases of heart failure, resulting in an incidence rate of 0.79 per 1,000 participants with a 80% power and an alpha error of 0.05. And based on this, they anticipated about 200 GP practices to be recruited, which results in an eligible study population of about 6,000 patients per study arm. So when we try to use these parameters into our own sample calculation studies, we enter these values into a software which giving the incidence rates in the experimental group and control group. They had assumed a coefficient cluster of 0.01, which is the factor we have to give because we expect all participants within a cluster to be of similar characteristics, and to correct for the same, they have used the coefficient of variation of cluster. The person years that they assumed was 60, and they had assumed a power of 80% with an alpha error of 2.5%. And based on these parameters, using the NMaster tool, we had calculated a sample size of 77 clusters. Whereas in the study, they had actually had even more clusters recruited, which was about 200, which we felt was an adequate sample size. So next, coming to the consort diagram of the study, there were about 397 practices who are in UK who are invited to be part of the study, out of which around 213 of them agreed to participate. They were randomized using a computer-based algorithm, and allocation was also concealed, and 109 of them were assigned to the control group and 104 of them were assigned to the intervention group. 8 of them were excluded before the onboarding visit, and finally 96 intervention practices followed the intervention group, which included about 7 lakh participants, and out of them around 12,725 participants had received AI stethoscope examination in 12 months, which indicates that the utilization of an AI-based stethoscope was only 1.81%. And even among 12,725 participants, only 6,500 of them had a clearly labeled patient identifier, whereas 6,224 of them, which is half of them, did not have a patient identifier with them. So they have reached their assumed sample size of 6,000 participants. And it is more than the cluster that we had calculated in our sample size calculation, which was adequate. So next, coming to whether the intervention, practice or service was clearly measured based on an implementation science variable or variables. For this, I have given a not sure because they have not clearly mentioned these clear-cut terms of implementation science outcomes. But when we looked at the studied outcomes and the discussion from the study, we were able to find out that they have evaluated certain outcomes of implementation science. Things that they have evaluated include coverage, acceptability, adoption and appropriateness. We did not feel that they have adequately evaluated feasibility. They have not evaluated fidelity, costs, or sustainability of using an AI-based stethoscope in clinical practice. So these variables were not formally defined also. Using these parameters are called derived from the Proctor's study on implementation science, and they have in the study they have not formally defined or operationalized using the Proctor's implementation outcomes framework. So did the authors define how they have measured each of these implementation framework outcomes? For this, I have given up not sure, because for certain variables they have described as to how they have how they have measured the outcome, and for certain variables we do not have the details as to how they have measured the implementation outcome. For certain variables like feasibility, they have used standardized questionnaires which were sent as an email to the participating doctors in the hospitals, and they were asked to respond to the emails, and questions were assessed using Likert scales and free text questions. So coming to the individual implementation outcomes, first looking at coverage, which is nothing but how much percentage of the eligible participants received the intervention per se. We saw in the consult diagram that only about 1.8% of the participants who are eligible to be examined with an AI-based stethoscope actually received the intervention, which is as low as about 1.8%. So second, coming to acceptability, whether the doctors are happy to use it in their routine practice, and what are the factors which will prevent the doctor from using it in a routine practice. They've used certain questionnaires which they've emailed to the doctors per se to assess the acceptability. Some factors which can affect acceptability is the knowledge of the doctor, whether he knows how to use the AI-based stethoscope, and his belief on whether AI works in clinical practice. Other thing can be time constraints, depending on the number of patient load in that particular hospital. All that they have assessed using standardized questionnaires, but the study per se did not report outcomes in terms of acceptability. The third outcome is adoption, as finding out how the study can be implemented as a policy in a healthcare system. Say, for example, the NHS in the UK. In the study, the study authors have said that for this study to be adopted into clinical practice, it should be cost effective, and there should be a good incremental cost effectiveness ratio to make sure that the NHS adopts it into clinical practice. But they have not done a specific cost effectiveness analysis or an incremental cost effectiveness calculation to find out whether this AI-based stethoscope will help in cost savings as an overall thing. And they have also assessed whether this new AI-based stethoscope can be implemented into the routine current practice. And they have determined that within the existing staff and workflows, this AI-based stethoscope can be effectively integrated without additional burden. And the fourth thing would be to assess whether the appropriateness of the intervention. This aims to assess whether in NHS it is not a routine practice to have a ECG done for the patients, because many of the centers did not have a routine ECG available in the healthcare setup. The pathway also does not have an ECG in the diagnosis of heart failure. It only required an NT-proBNP testing and echo testing and subsequent diagnosis of heart failure. So the study authors have said that using this tool, that because this has an integrated ECG per se, it would be more appropriate to use it in clinical practice. And next, coming to feasibility as to whether the AI-based stethoscope can be implemented into routine practice. Things to consider would be whether the training is minimal or practical, and does it fit into routine examination workflows, and whether the general practitioner can include an AI-based stethoscope examination within a 10-minute consultation that he has for each patient. So this is the graph showing the utilization rates of general practitioners in using the AI-based stethoscope. And there was a clear trend that the usage of the AI-based stethoscope was significantly becoming lesser throughout the entire duration of the study. There were numerous factors as to why the use of AI-based stethoscope declined, and they had used standardized questionnaires to assess the same, which you'll be seeing it in the coming slides. So these were the questionnaires that were asked to the healthcare providers in the primary care practice to find out why they were not using the AI-based stethoscope. And even for the questionnaire that they had sent, only about 15% of the doctors had responded to the questionnaire. And some factors that they had felt was the reasons for not using was absence of integration of the stethoscope into the routine health EHR workflow. And second thing was the frustration to workflow, wherein though the protocol says recording of the keeping the stethoscope in the diaphragm for about 15 seconds to get a ECG waveform, many of them might have not actually got an adequate waveform, and it might have taken some time for them to get the waveform, and this resulted in frustration for the doctor. And for identifying enablers for using AI-based stethoscope, some 52% of the doctors had said that giving financial incentives to use an AI-based stethoscope could improve adoptability of AI-based stethoscope in clinical practice. So next, the sixth outcome would be fidelity. Fidelity is nothing but how many adhere to the protocol of how exactly the stethoscope should be used as defined in the protocol. The stethoscope used is the Echo Duo stethoscope, and the participating doctors had been given a 1-hour training on how the stethoscope should be used, the setup, and how it should be utilized in clinical practice. And it required placing the diaphragm of the stethoscope in pulmonary position for recording for at least 15 seconds. So, but the study per se did not assess as to how much percentage of the doctors actually followed this protocol. So we are not able to give a clear-cut answer to this question. So where issues of confounding addressed, for this I have given a not sure. First, because though in a randomized control trial, we expect both the confounding and the unknown confounders to be equally distributed. The study per se has also done a per protocol analysis using just 1.8% of the participants who had received AI-based stethoscope examination, wherein we are not sure whether the baseline characters were equally distributed. So some confounding factors which I felt were not addressed were included whether the physician's clinical skills could have affected as to the diagnosis of heart failure, whether the time spent with each patient could have influenced the diagnosis of heart failure, and the adoption of AI-based stethoscope could have influenced the diagnosis of heart failure. And the fourth thing was the gold standard that they had used for the diagnosis of heart failure was an ICD or a SNOMED labeling of the diagnosis of heart failure in the EHR workflow algorithm. So I might have one different term as to how I label a patient with heart failure. Each one of us might have different terms. I might call it acute decompensated heart failure. Someone else might call it congestive heart failure. So there are numerous different terms for heart failure. So whether that would have resulted in some patients getting missed is not sure. Some factors which they are not adjusted for included smoking status, and for atrial fibrillation factors like hypothyroidism. So this is an example of SNOMED coding that they accepted as a diagnosis of heart failure, which included acute heart failure, congestive heart failure, etc. But the study per se, in the per protocol analysis, they had done a propensity score matching wherein they adjusted for age, gender, and comorbidities, which can influence both the risk factors and the outcomes, which included diabetes, CKD, coronary artery disease, hypertension, and cancer. And the propensity score matching was done to address for the confounders. So the next question would be, was an appropriate recommendation given based on the implementation study? Finally, the authors have concluded that for this AI-based stethoscope to be used into routine practice, it requires linking the tool with the electronic health records. And they also said that selective deployment could increase the diagnostic yield, and financial incentives can be given to the hospital per se to enhance the use of an AI-based stethoscope in clinical practice. So next, coming to a brief summary of the results, our study's primary outcome was to find out the incidence rate ratio of detection of heart failure using an AI-based stethoscope as compared to routine practice. And in the intention to treat analysis, for the diagnosis of heart failure, the incidence rate ratio was 0.94 with a confidence interval between 0.87 to 1.0, which essentially meant that there was no difference in the incidence rate ratio in the diagnosis of heart failure using an AI-based stethoscope as compared to routine practice. And the p-value was also not significant. The co-primary outcome was whether it improved the diagnosis of heart failure in the community as compared to diagnosis of heart failure at the hospital. Even here, the adjusted incidence rate ratio was not different, and it did not improve the diagnosis of heart failure in the community setting. So additionally, the study has also done some sensitivity analysis, which they have not initially pre-planned prior to the beginning of the study. In the per protocol analysis, instead of using the entire population as the denominator, they have specifically used a denominator of 8,942. They have arrived at the numbers based on the number of participants who had received at least one AI stethoscope examination. Though in our considered diagram, we had seen around 12,000 participants received an AI-based stethoscope examination. Here, the per protocol analysis used a number of 8,942. They have not clearly mentioned in the study as to how exactly they arrived at this number. One thing we thought was a single patient might have also received 3 to 4 AI-based stethoscope examination, which could possibly kept the numbers at 12,000. And considering single examination separately, the numbers could have been 8,942, but we are not exactly sure as to how the numbers were reached. So when they did it as a per protocol analysis with the factor of whether using an AI-based stethoscope per se will improve the diagnosis of heart failure, the study authors have found that the incidence rate ratio was higher at the range of 2.33 for the diagnosis of heart failure with a confidence interval between 1.28 and 4.26. And the p-value was also statistically significant. But given the fact that this is a sensitivity analysis, the result findings should be taken with caution. So next, the secondary outcomes included finding the diagnostic accuracy of AI-based stethoscope in diagnosing heart failure. With regards to heart failure, the sensitivity of the AI-based stethoscope was 39% with a specificity of 92%, with a positive predictive value of 30% and a negative predictive value of 95%. The positive likelihood ratio that the study authors found was 5 with a negative likelihood ratio of 0.67 with an F1 score of 0.34. So what is this F1 score? This is a new term that has now been utilized more and more in many modeling methods and AI-based studies to analyze the study's performance or a model's performance. Instead of using an accuracy per se of a study, the F1 score per se takes into account both the precision of the study as well as the recall of the study. What exactly is precision? Precision is nothing but true positives among those who test positive, which is essentially same as the positive predictive value of the study. And recall is nothing but true positive among those with the disease, which is the same as sensitivity of the study. So the F1 score can be calculated as the harmonic mean between precision and recall, calculated by the formula of twice into precision into recall divided by precision plus recall. The advantage of using harmonic mean is that if one of these values are on the lower side, the F1 score will also be significantly low. Only if both the values are sufficiently good enough, the F1 score will give a decent number for the current model. So the F1 score assesses how often we are right and how many did we catch among those who have the disease. The range of F1 score can be between 0 to 1, and a study is said to have a good performance if it has a score of about 0.7 to 0.19, and if it is said to be great if it has a F1 score of 0.9. Whereas in our study, for our primary outcome of heart failure, our F1 score was only 0.34. So next, coming to the Fagans nomogram, we'll try to apply the study's likelihood ratio for our clinical scenario. Just recollecting our clinical scenario wherein we had a patient presenting with a 2-month history of pedal edema with a background history of diabetes with a normal clinical examination with the doctor thinking of the possibility of a patient having a heart failure. What do you think is the pretest probability of a patient with heart failure? He had no dyspnea on exertion. He did not have an elevated JVP. He did not have an S3 or an S4. He has come to a primary practice. And what do you think would be the pretest probability of this patient having heart failure? %20. Any other? 5%. So for my scenario, I have taken a pretest probability of 20% and taking the positive likelihood ratio to be around 5. The post-test probability of the patient having heart failure still remains around 55 to 57%, which is like say like tossing a coin, like a 50% chance of having or 50% chance of not having a heart failure. The negative predictive value per se did not make any difference because with a participant having 20% base pretest probability of heart failure, taking into account a negative likelihood ratio of 0.67, the post-test probability of heart failure still remained around 15%. So the study per se did not make any difference. So next, another hypothetical scenario, say for example, you are the emirate in the casualty and some patient has presented with some 60-year-old gentleman has presented with complaints of exertional dyspnea, PND, and orthopnea for the last 5 days, and he has active chest pain. And you note that the patient has an elevated JVP with a pitting pedal edema and S3, S4, and is requiring NIV in the emergency department. In this scenario, what do you think is the pretest probability of the participant having heart failure? 90%. 70. Any other takes? 90. Okay. So in my study, in this scenario, I have assumed a possibility of around like 70%. And taking into account this positive likelihood ratio of about 5, the post-test probability becomes about 93%. And for the negative likelihood ratio of 0.67, the post-test probability still remains around 60%. So in this scenario, in a patient who has a pre-test probability of around 70 to 80%, the study per se will not change the management of heart failure. So, can the results be implemented into a similar population? Coming to our primary healthcare setup, will it be different from the primary healthcare setup in UK? This is one study which in Kerala which showed the baseline comorbidities of our population attending primary healthcare, which was more or less equal to what they had found in the UK's clinical practice. And whether we can implement in our primary healthcare centers, some problems that we might face is we do not have an effective health record system in our practice. And our patient load might be significantly maybe higher on the higher side as compared to UK. And the cost per se will also be have to be taken into account given that we are a middle income country. So uh, for us to analyze the costs of utilizing a AI-based stethoscope, here I put forward the cost of a usual stethoscope and an AI-based stethoscope. Uh, the first one is a Littman cardiology force stethoscope. The cost of it is approximately 18,000 as of today in Amazon. And the cost of AI-based stethoscope, this is the Echo Duo stethoscope, which was used in the study. And as per the company's official website, the cost was around $400, which is approximately 40,000 rupees, which is about twice the price of a Littman stethoscope. So if you had to supply at least one stethoscope to all of the primary healthcare centers in the country, there are about some 30,000 primary healthcare centers all over the country. And the difference being 20,000 for each stethoscope. It comes to about 60 crores to implement this AI-based stethoscope into routine practice in India. So we'll have to find out whether we can disinvest resources in other for other diseases and use these resources for our setup and utilize this AI-based stethoscope. And we need to do further cost effectiveness analysis to see whether this will ultimately end up saving costs in terms of heart failure mortality and heart failure admissions, which remains to be found further. So can the study be used to further the implementation science variables? Yes, I've given a yes to this question. And what are the implications of the study for implementation science practice? From the study, we find that having a technology per se, an AI-based technology per se, will not essentially guarantee it will improve clinical outcomes or improve mortality. There are some practical factors which we have to consider, including clinicians adoption, workflow integration, and finding out why there's a low uptake by clinicians to implement this AI-based thing into clinical practice. Other factors which you have to consider is enough training and engagement of the clinicians in utilizing this AI-based stethoscope and finding out how we can implement this into our routine practice. And what are the implications of the study for implementation science research? For further studies which uses AI-based stethoscope for clinical practice, it would be ideal if they could use uh, a framework for assessing implementation science and to evaluate implementation science like the CFIR or the REAIM framework. And the study should per se should implement outcomes in terms of the Proctor framework model for implementation science. And the study per se did not assess factors like cost effectiveness or sustainability in the long term, which should also be addressed in future studies. So coming back to patient A, given this all these factors put in together, I would like to conclude saying I would not be using a AI-based stethoscope for this participant at with whatever evidence is available at present. So before we could end the session, I just wanted to give a small scoring for the study using the assess tool. So to analyze the results of the study, I've used this assess tool to give a scoring system for each of the outcomes of implementation science. The first thing we had to do to analyze the study is to find out the design type. Our design type of the study was a quantitative RCT, and the questions to be answered to give a scoring is to find out whether the randomization was appropriately performed, for which I have given a score of 1, and whether the groups were comparable at baseline. We found that our study population was similar at baseline, so I have given a score of 1. And is there complete outcome data? We found that many of the implementation outcome variables were missing in our study, so I have not given a score of 1 to this question. And are the outcome assessors blinded to the intervention provided? This was more of a pragmatic study, so blinding was not feasible, so they have not practiced blinding. Hence, I have given a score of 0. And did the participants adhere to the assigned intervention? For this, again, I have given a 0 because though about 7 lakh participants were randomized to the AI-based stethoscope arm, only about 1.8% of them ended up receiving the intervention. And this scoring, I've given it for the implementation strategy. And with regards to intervention strategy, again, for randomization, I've given a score of 1. And comparability at baseline, I've given a score of 1. And whether there is complete outcome data, in terms of the diagnostic accuracy, they have given a complete outcome data. Hence, here I've given a score of 1 as compared to 0 with regards to the implementation strategy. And the last factor that we'll have to do is to give a scoring for the outcomes of implementation research. For acceptability, I have given a low risk of bias. For appropriateness, I have given a low risk of bias with a score of 4. For adoption, I've given a score of 4 with low risk of bias. And for feasibility, I've given a score of 2. The study did not appropriately assess fidelity, penetration, cost, and sustainability. Hence, I've used not applicable. Hence, the overall score for the implementation strategy was 15. And the overall score for the diagnostic accuracy is 15 from our study. Yes, sir. This has an overall score of 5, and here the overall score was 25. So overall score was 13 together. So thank you. I'd like to thank Dr. Tambu sir and Dr. Vignesh sir for helping me with the presentation.